Good morning, and thank you very much for this opportunity to present here. I will talk about a little bit about the evolution of STA to MCA bypass and the clinical trials. I'll talk about the current or the common indication, and I will discuss a few cases. So actually, this is Dr. Yasser Gil. He introduced this procedure. By the way, that's his wife next to him. She was his scrub nurse for many years. He also introduced the microscope to neurosurgery, and he did it actually. The first case was done in 1967. In 1967, he performed the first case. He then published it in 1977, like 84 cases with great results. By the way, this is how we do it today, so it's just the same procedure. Perioperative, we manage it a little bit different, but same procedure with a little bit of a better microscope, and here this is done with an exoscope as well. By the end of the 80s, they were very satisfied with the results. They went for the ECIC bypass trial, which is the first randomized controlled trial. They actually managed to recruit almost 1,400 patients, half to medical treatment and half to surgical treatment. They did follow them for almost 5 years, but the results were very bad for the surgical arm, and as they call it, failure of extracranial intracranial bypass. The surgical arm had 12.2 strokes versus medical arm 3.4, and major strokes of 4.5% versus 1.3 to the medical arm. And as you can see, the Kaplan Meier curve never crossed, and the surgical arm was worse in respect to all other subgroup analyses that were done. The anastomosis patency was very good, actually, 96%, and they did assess it with formal angiogram. So this was really good patency of these bypasses. But they actually did not assess the perfusion deficit. So here's a patient arrived to us with a chronic occlusion of his left intracranial, of his left internal carotid artery with strokes. This patient would definitely been randomized into that trial. But when you look at his perfusion study, he has no perfusion deficit at all. He doesn't need this flow. So mid-80s, they started doing lots of perfusion studies. They used PAT. They did manage to create kind of stages. First stage is the first drop in CPP. Second stage is the interesting stage, which they call misery perfusion state, where there's further drop in CPP. The CVR, which is the cerebral vascular reserve, will be reduced, and the oxygen extraction fraction will increase in order to compensate for hypoperfusion. Stage 3 is actually end-stage ischemia. Multiple trials using the PET, but this is a key trial. It's a prospective, randomized, blinded trial. They tried to assess whether stage 2, this misery perfusion state failure, carries a higher risk for recurrent strokes. And as you can see, at 2 years, these stage 2 patients had almost 30% recurrent strokes, while the normal OEF had 9%. And when you see the Kaplan Meier curves for all strokes and for ipsilateral strokes, the stage 2 patients continue to experience after 2 years more and more strokes, while the normal OEF actually achieved a plateau and did not experience more strokes. So they thought they had an idea, and they'll recruit, then they'll do another trial. And this is obviously the second clinical trial in bypasses, the COST trial as we call it. They wanted to recruit 354 patients. They thought that the medical arm will carry 40% recurrent strokes, but they did actually in the end only recruited only 195 patients, and I'll talk about that as well. All of them had hemodynamic compromise with increased OEF, about 100 and 100 per each group. This study actually was terminated for futility, but at the 6-month post-futility analysis, they actually found some errors. 4 patients in the medical arm had strokes, but they were not included. So actually the trial should not have been stopped. But anyways, they did follow the patient for 2 years, which, as we saw, was a short period of time, but there were no differences between the surgical arm and the medical arm. At 30 days, ipsilateral strokes in the surgical arm was 14.4. So most of it is peri-op. 12 patients within 2 days experienced a stroke, and the medical arm only 2%. They did manage to reduce to the OEF, but they did not normalize it. So that was one of the problems. But the most important thing from this cost trial, I think, is this Kaplan Meier curve. As you can see, just as the trial, the samples, most of the strokes happened in the first 2 days. But at this point, actually, there's a cross. The surgical arm becomes better than the medical arm. And this is the trajectory of the curve of the medical arm. This is the trajectory of the curve of the surgical arm. So I actually don't know what would have happened if they did manage to continue and recruit another 150 patients and for a longer period of time. Maybe surgical arm would be better. Anyways, the major questions from the cost trial were which patients carry extreme risk for the recurrent strokes, and can we reduce the perioperative strokes? So what are the current common indications for bypasses? First of all, this patient needs to have recurrent strokes with significant hypoperfusion state. He needs to fail best medical treatment. And most importantly is which kind of a lesion does he have? I think there are 3 options. Either there's no endovascular option, like complete occlusion of the cervical carotid. If the lesion is complex and there's no safe endovascular option, or the patient that failed endovascular option. So this is a 62-year-old patient with hyperperfusion state. But when we saw the angio, you can see that there are 3 stenotic lesions in the intracranial ICA, and there's another one in the distal M1 segment. So we thought that's not a good candidate for stenting, or not safe option. This is just to demonstrate the procedure. We used here the exoscope, which is very easy to use. You can do the whole procedure skin to skin with the exoscope. We dissect the STA of the scalp. We leave a cuff, so to avoid any spasm of the donor. We elevate the temporalis muscle. I always verify that the recipient is a little bit larger than 1 millimeter, otherwise it's very difficult to do the anastomosis. We fish mouth the donor in order to provide more flow into the anastomotic area. I do use interrupted sutures. There are multiple ways to do that. Can do also Rannick sutures. It doesn't really matter, I think. We then use an ICG just to verify that there's good flow into the anastomosis. Here's another case. This is a patient that failed best medical treatment. She has a lesion in the M1 segment. She was treated in a different hospital. They thought it's a good candidate for stenting. She underwent balloon angioplasty. You can see a great result. But she failed, arrived again with another stroke. They did another balloon angioplasty, but she failed again. At this point, she actually was perfusional. She had weakness of the hand when she was standing. This is a perfusion study. We did the bypass, and you can see there's reconstitution of flow of the proximal M3 segments as well. And this is the CTP before and the CTP after. And to summary, I think this disease and this option must be done with the team approach. The decision to revascularize needs to be taken early post-medical failure, I think. And I think we need to do a direct bypass in this current indication in high volume centers for complex lesion or for failed endovascular treatment. And thank you.